Good afternoon, ladies and gentlemen. You're very welcome to join us today. It is, of course, our monthly Tuesday ERN-RITA webinar. We are delighted every month that we have focused topics that are based upon rheumatological, immunological, and I will say renal for all those nephrologists out there as well. We have a very special and very popular webinar for the next hour. We're delighted that so many of you are with us today. We are discussing the pathogenesis and treatment of eosinophilic granulomatosis with polyangiitis. It's part of the Tuesday lunchtime RITA seminar. To join me now, I would like to welcome Professor Alfred Marr. Alfred.
Hello, good afternoon. I'm Alfred Marr. I'm an internist working in Switzerland, so I'm happy to chair this webinar together with Alison Egan, who is a nephrologist from Dublin in Ireland. So when you have questions to ask, please use the question section of the webinar system, and we're happy to take your questions and to forward them to the speakers. As mentioned, today we're addressing the topic of eosinophilic granulomatosis with polyangiitis, EGPA, formerly called Churg-Strauss syndrome. We're going to talk about the pathogenesis of the disease and the treatment of the disease. We're delighted to have two renowned speakers, both from Florence in Italy. First, we have Dr. Giacomo Emmi. He's an immunologist of the University of Florence. And then we have Professor Augusto Vaglio. He is a nephrologist from the University of Florence. Giacomo and Augusto actually don't work in the same institution. They both are members of the European Society for EGPA, and they just published a month ago an evidence-based guideline for the treatment of EGPA in Nature Reviews for Rheumatology. I think we're ready to start. Giacomo, we will start with you with the treatment of eosinophilic granulomatosis with polyangiitis. And then we will take questions for Giacomo, and then we will hand over to Augusto for the pathogenesis. Giacomo, thank you for being with us. The floor is yours.
Thanks. Good morning, everyone. Can you see my screen?
We do, Giacomo. It's perfect.
Okay,
we see your screen and we hear you perfectly.
Okay. Thanks for the invitation and also for the introduction. I will try to briefly depict the main treatment options we have for the treatment of eosinophilic granulomatosis with polyangiitis, as Professor Marr said, formerly known as Churg-Strauss syndrome. And we know that EGPA is classified among ANCA-associated vasculitis together with leukocytic polyangiitis and granulomatosis with polyangiitis. And clinically speaking, traditionally has been the disease has been classified in different disease phases. So the first one is known as an allergic phase, which can last for several years, and which is characterized by respiratory manifestation together with peripheral eosinophilia. And then we can have an eosinophilic phase of the disease, in which the invasion of eosinophils in the target organs such as heart, lungs, and GI can manifest as cardiomyopathy, lung infiltrates, and gastroenteritis. And lastly, we can have a vasculitic phase of the disease, and in this phase, usually the disease tends to accelerate, and this phase lasts a few weeks or sometimes days. And we still have peripheral eosinophilia, but also vasculitic manifestations as peripheral neuropathy, purpura, and glomerulonephritis. And when looking at the treatment of EGPA, and firstly looking at traditional treatments, but in general, I would say looking at the treatment of EGPA, we tailor the treatment based on the patient's prognosis score, which is actually based on this 5-factor score, which is a score proposed by the French vasculitis study group almost 20 years ago, which includes some main and severe, I would say, manifestations such as renal involvement, GI involvement, myocardial involvement. So all the patients who have a 5-factor score equal or greater than 1 have to be treated with corticosteroids and immunosuppressants, and specifically we will see cyclophosphamide. While patients with better prognosis, so with a 5-factor score equal to 0, can be managed with corticosteroids alone. We also have some manifestations which are not included in the 5-factor score. For example, severe peripheral neuropathy, or more rare manifestations as CNS involvement or alveolar hemorrhage. And also these kind of manifestations obviously have to be treated not only with corticosteroids but also with immunosuppressants. And there are some studies, all by the French vasculitis study group, for the treatment of patients with EGPA with traditional immunosuppressants or corticosteroids, and for patients with a non-severe EGPA, so a patient with a 5-factor score equal to 0, we can, as we said, use glucocorticoids alone. And this data is based on this trial, which has been published by Ripier and colleagues. And these 72 patients treated with glucocorticoids, 93% of patients achieved the remission, but at the tapering of the glucocorticoid treatment, almost 1/3 of these patients relapsed. So glucocorticoids are effective for inducing the remission of the disease, but when we taper the treatment, usually we have a new manifestation of the disease, so a relapse of the disease, which is something that we usually see in our clinical practice. Adding in this phase, so for inducing the remission for non-severe EGPA patients, so adding immunosuppressants, and in this case, in the CHOOSE-PAN-2 trial, the azathioprine seems to not to add any beneficial effect in terms of relapsing-free survival, and also for reducing glucocorticoids during the follow-up. So patients with a 5-factor score can be treated with glucocorticoids alone. Differently, patients with a severe EGPA, so patients with a 5-factor score greater than 1 or equal to 1, so with usually life-threatening manifestations or more severe manifestations, have to be treated with glucocorticoids and immunosuppressants, and namely with cyclophosphamide. In this study, in this trial, again by the same French group, the longer the treatment with cyclophosphamide, the better the disease-free survival rate, which is something we can translate in our clinical practice. So patients with severe disease have to be treated for at least 6 months, maybe better 12 months with pulses cyclophosphamide. When looking at the main pathogenetic mechanisms of EGPA, and Professor Vaglio obviously will talk in a more detailed way about this topic, but we can essentially imagine that we have some damages driven by vasculitic manifestations, deformation of granulomas, and this is something which is related to the interaction between B cells, T cells, neutrophils. So we can use drugs which are able to interfere with these mechanisms. On the other hand, we have an organ damage driven by eosinophils invasion of target organs, which is driven by mainly cytokines, I would say, and basically IL-5, obviously, but also there are other cytokines involved in this process. So we can imagine to treat different phases of the disease with different drugs. For example, rituximab. At this stage, at this moment, we only have some retrospective, small retrospective core studies, which suggested that rituximab can be beneficial both for the induction of the remission of patients with EGPA, but also for the maintenance of the remission. And in, I would say, all these retrospective studies, ANCA positive patients tended to have a better response when treated with rituximab as compared to patients without ANCA positivity, which is something that has not been confirmed by these multi-center randomized controlled superiority trial comparing rituximab with conventional treatment strategy for the remission induction in EGPA. We do not have actually the extending version, so it's not already published as a extending paper, but we have the data presented almost 2 years ago at ACR in forms of abstract. So the EUVAS trial, again, led by Benjamin Terrier and the French study group, evaluated both patients with newly diagnosed or relapsing EGPA and treated with rituximab and cyclophosphamide in patients with 5-factor score greater than 0, and in the other arm, rituximab and glucocorticoids alone in patients with a 5-factor score equal to 0. This is the design of the study. So you can see that patients with worst prognosis score, so a 5-factor score greater than or equal to 1, had been treated with rituximab or pulses cyclophosphamide, while patients with a 5-factor score equal to 0 had been treated with rituximab or placebo, so mainly glucocorticoids. And the data we have, actually, this was a superiority trial, so rituximab did not meet the endpoint. So rituximab is not superior to conventional strategy for induction, the induction of remission in EGPA. The remission rates and relapse-free survival in the short term, so in the first 52 weeks, were comparable between the two arms, and also no differences emerged in the different subgroups this study evaluated, so especially ANCA positive versus ANCA negative patients, newly diagnosed or relapsing disease, and also patients with a 5-factor score equal to 0 or patients with a 5-factor score greater to 0. Moving to the anti-cytokines treatments, we know that IL-5 is a target cytokine. We have drugs which are able to interfere with IL-5, and especially mepolizumab, which is a humanized monoclonal antibody which is able to interfere, so to block, to bind circulating IL-5. So IL-5 is not able to interact with the alpha chain of its receptor, and the study, which formally showed us the beneficial effects or efficacy and safety of mepolizumab at a dosage of 300 mg every 4 weeks in relapsing refractory EGPA, is actually known as a MIRA trial. And the primary endpoints were the acute week of remission, and the remission was defined as a EUVAS, so an activity score equal to 0, and a prednisone dosage less or equal to 4 mg a day, and the proportion of patients in remission at index weeks. And the trial met all these endpoints, so a significantly more acute weeks of remission, a higher percentage of participants in remission at weeks 36 and 48, but also showed a lower relapse rate in patients treated with the anti-IL-5 drug, and also a very important lower need of prednisone in the mepolizumab arm. This trial has some weeks. The patients had not severe disease. Only 10% of the patients had ANCA positivity at the beginning of the study, and also only half of the participants treated with mepolizumab met the protocol-defined remission. However, actually, mepolizumab 300 milligram every 4 weeks is the only drugs approved for EGPA. There are two main post-MIRA experiences, all retrospective observational. The first one, again, by the French vasculitis study group, together with the European EGPA study group. And in this study, 150 patients were evaluated, and in particular, the treatment with rituximab, omalizumab, and mepolizumab were analyzed, and rituximab confirmed its efficacy, especially in patients with more severe disease, while mepolizumab, this was the first study showing in the clinical practice that mepolizumab is able to control disease in this study in a very, I would say, dramatic way, because at 12 months, the rate of remission was almost of 80%. So almost 80% of the patients have achieved the remission, both with mepolizumab 300 milligram per month. So the dosage approved for EGPA, but also with the lower dosage of 100 milligram per month. This was the first study suggesting these data. More recently, we collected within the European EGPA study group a larger cohort of patients, so 203 patients treated with mepolizumab 100 milligram every 4 weeks, which was the larger cohort of this population, and while only 35 patients were treated with mepolizumab, the dosage approved for EGPA. However, we showed that no significant differences were observed between the two dosages, so between 100 milligram and 300 milligram, in terms of complete response as defined in the MIRA trial, and also in terms of disease activity or in terms of reduction of prednisone dosage during the 24 months follow-up. And also no differences emerge in terms of respiratory outcomes between 100 milligram and 300 milligram per month. No new safety concerns emerge in this study. More patients treated with 300 milligram experience adverse events requiring also hospitalizations rather than patients treated with the lower dosage. More recently, we also collected data of sequential rituximab and mepolizumab treatment. So we collected data of 38 patients treated with mepolizumab and with rituximab, and within 12 months mepolizumab, without any other induction of remission treatments between these two therapies. And again, rituximab was mainly prescribed, used for patients with active disease, so with the patients with an active vasculitis. In 36 over 38 patients, the systemic disease or severe systemic disease was the main driver of the treatment choice. So the median EUVAS of these patients was of 10, and while patients treated with mepolizumab were mainly treated for respiratory manifestations. And you can see that obviously rituximab was able to significantly reduce the disease activity, and also partially to reduce the prednisone dose and the eosinophil count, while the respiratory manifestations were obviously not well controlled by rituximab, while adding mepolizumab obviously led to a significant amelioration also of respiratory manifestations. The last two slides, as Professor Mar said, there are new recommendations for EGPA. There are EULA recommendations for AAV, which also includes some recommendations for EGPA. And more recently, we published this evidence-based guideline, and we can summarize the treatment of EGPA looking maybe at this slide. So patients with new onset active EGPA, so patients with a new onset disease, who have a severe disease, so or 5-factor score greater than 1, or other manifestations such as peripheral neuropathy or alveolar hemorrhage or other life-threatening manifestations, have to be treated with high-dose glucocorticoids plus cyclophosphamide or rituximab for remission induction purpose, while remission maintenance with glucocorticoids or rituximab and or mepolizumab, which is a good option. For patients with a non-severe disease, so 5-factor score equal to 0 or other, so the absence of other main organ manifestations, the remission induction can be managed with glucocorticoids, so a short-term glucocorticoid treatment, while the remission maintenance with glucocorticoids and mepolizumab. And relapsing EGPA, so we distinguished severe systemic relapse or non-systemic, non-severe systemic or only respiratory relapse. So in the first case, again, high-dose oral glucocorticoids, rituximab or cyclophosphamide, rituximab especially in patients already treated with cyclophosphamide or patients who cannot be treated with cyclophosphamide for safety concerns. While for non-severe systemic manifestations or patients with only respiratory manifestations, we can use glucocorticoids alone or mepolizumab. So this is the last slide, and I think we can say that we are really going towards a personalized management of EGPA patients. So for patients with a severe disease, we have cyclophosphamide, we have rituximab. We do need more data about effectiveness and also safety of mepolizumab for patients with life-threatening manifestations. For cortico-dependent asthma, for sure we can use mepolizumab, maybe, but we are waiting data from the MANDRA trial, which is a trial comparing mepolizumab and beralizumab in EGPA. For nasal polyps and sinusitis, obviously we can try to use mepolizumab. In the future, maybe dupilumab. There's an observational study led by Benjamin Terrier, who collected about 50 patients treated with dupilumab. Dupilumab seemed to be effective for ENT manifestations, even if there are some concerns about the safety of dupilumab-induced eosinophilia in patients with EGPA. And finally, for patients with ANCA-negative EGPA patients, which can have some features of idiopathic eosinophilic syndrome, mepolizumab, which is approved for both the disease, but also beralizumab and imatinib mesylate could be an option for this kind of phenotype. And thank you for your attention.
Thank you very much, Giacomo. What a fantastic tour de force, talking us through the interesting options that we now have for therapeutics of EGPA. If we go back and look at this, say for severe disease, new presentation of severe disease, we have the options of both cyclophosphamide and rituximab. When you're choosing, you're in front of a patient, what are the features that you use to decide the difference between your choice of cyclophosphamide or rituximab?
I think it depends on the, so first we do need to have more solid data, so published that data for rituximab before saying that we can use either cyclophosphamide and rituximab, even if we know that we have some good data from the abstract of the EUVAS study. And I think that for more severe manifestations, for example, alveolar hemorrhage or glomerulonephritis, even if it's quite rare, maybe clinically I would prefer treatment with cyclophosphamide over treatment with rituximab, but we use a lot of rituximab, especially for patients already treated in the past with cyclophosphamide, and also with patients who cannot treated with cyclophosphamide for safety concerns, so patients, elderly patients with other comorbidities. So this is the main drivers of my clinical choice.
If you in cardiac disease, would you still have a preference towards cyclophosphamide over rituximab, would you say?
Yes, at the moment I never use rituximab for active cardiac involvement. For myocarditis, for example, we use high dosage of glucocorticoids and cyclophosphamide. So we need more specific data for cardiac involvement in this disease, I think.
So, I mean, EGPA has really led the field with, with the MIRROR trial, and that we have cytokine-targeted therapies in anti-IL-5s. It's very interesting in the European EGPA study that both 100 milligrams and 300 milligrams had very similar efficacy.
Yeah, this is something we do in our clinical practice. So we in our clinical practice, because we did not use, obviously, MIPO 300 milligram before the approval of the drug. And still today, even if we have obviously drug approved for more, so patients with a better prognosis, so patients with mainly respiratory involvement without any other systemic manifestations, at our center we use the lower dosage, and eventually we increase the dosage during the follow-up if the patient need to add something more important for new manifestations, so for a better control of also sometimes respiratory manifestations. What we prefer to start at the lower dosage. I know that there are other centers which use a different approach, so which start at higher dosage and then eventually taper MIPO, which is something makes sense, obviously.
Okay, now I'm going to do a few, because we could be here for the whole afternoon. I have a couple of quick fire questions coming in from the question panel. So avacopan in the treatment of EGPA, do you think that's something that we could consider going forward?
I don't know. To the best of my knowledge, there are no studies running on this topic. Obviously, especially in patients with more vascular manifestations and ANCA positivity, so in which we can imagine that neutrophils are more involved in the pathogenesis of this disease. This might be an option, but I don't know. I don't have a good response for this.
Okay, next question was 6 months versus 12 months of cyclophosphamide. Do you think would you use the same dose, and what about toxicity? That was a question.
What about toxicity? I think that I know that, for example, you as a nephrologist, you are more keen to use higher dosage of cyclophosphamide, but in general, I think that 12 pulses of cyclophosphamide, usually at a dosage of 600 milligrams for square meters, is not a high dosage. So I don't think we have really safety concerns for these dosages of cyclophosphamide. Obviously, the longer is the treatment, the better is the response in terms of relapse-free survival. So I think that we have to treat patients till the disease is in remission. So the 6 months versus 12 months is something which has been used in the trial, but sometimes we need more time for inducing remission in these patients, or sometimes 6 months can be enough.
And then another quick question here, something we've spoken about recently at the EGPA Society meeting, MMF, any chance of induction or maintenance? We did discuss this a little bit. It's an area of interest. That was a question that came in the topic.
Yeah, we are waiting for also the data of the main RITSEG trial, which is again a study from the French vasculitis group, which is very active in the field, obviously. And looking at the observational and retrospective studies, we have very few data, and we published a very small cohort a few years ago, but the data we provided suggested that differently maybe from the other ANCA-associated vasculitis, using rituximab or as a maintenance treatment every 6 months is able to maintain efficiently the remission in these patients. So we use in our clinical practice rituximab for remission maintenance purposes.
I'm going to do a final comment because we're about rituximab followed by MECO, something else. Now, I know you've shown that, you gave us a lovely graph on that, and we'll just highlight that as a comment as we go through, as we come to the end of the question time. I'm going to hand over to Alfred now. We will invite Augusto to come and give his talk on pathogenesis. Giacomo may be with us for a little while at the end, but we thank him very much for his contribution. It's been a fantastic half hour. We could continue for the whole hour, as you can see. Alfred.
Thank you.
Yeah, thank you, Elliot. Thanks, Giacomo. Maybe some of the questions that still pop in about the treatment could also be answered by Augusto Vaglio, who is coming up next. Augusto is, as I mentioned, a nephrologist from the University of Florence in Italy. Augusto has long-standing interest in EGPA, and Augusto will talk about the pathogenesis. Augusto, you're here. We can see you so far.
Can you hear me?
Yes, we can hear you.
Yes. Okay. I share the screen.
We'll let you know.
Yeah.
Not yet. Now we have it.
Yes, thank you.
Augusto, also your webcam, please.
Okay. So I move on. Okay. I move to the first. Can you see this second slide?
Yes, we see it. Can you switch on your webcam or?
So good morning, everyone, and thanks to the organizers of this webinar. And I think it's stimulating discussion on this topic. And I will discuss the pathogenesis of EGPA, starting from some clinical observations and going through some more mechanistic or molecular studies. And I will touch on these 4 main points. First of all, the clinical and histological components of the disease, then the influence of genetics and environment, and then the immunopathology with the cellular and human responses, and finally, we will see that a disease model that tries to summarize the different aspects of the disease. So Giacomo already showed the timeline of a usual patient with EGPA. So that I think there is a structure of the disease which is not only sort of time dependent, but also depends on different immune pathogenesis of the phases of the disease. So we know that the disease starts with this allergic, I think inappropriately defined allergic phase, which is hallmarked by asthma and ENT manifestations and can last for several years. And then the progression to a more eosinophilic phase with heart disease, lung involvement, GI, skin lesions, and then in some patients, not all patients, we see the appearance of vasculitic features such as neuropathy, purpura, or crescentic nicotizing glomerulonephritis. But the most intriguing thing in this progression of the disease is that even when you treat these patients with high-dose glucocorticoids, with traditional immune suppressants, and also with rituximab or other B-cell depleting agents, you will see the disappearance of the main systemic features, but the core of the disease remains. And so we have to switch from these more toxic therapeutic approaches to low-dose glucocorticoids and IL-5 targeting agents, because this core of symptoms, this core of clinical manifestations, which probably depend on a sort of persisting Th2 activation in the respiratory tract, remain. So I usually define this as a matryoshka structure of the disease, where you can treat the external parts of the systemic features, but something remains. And this is something that can persist for the entire life of the patient and makes the patient steroid dependent. So there is an initial dichotomy in the clinical manifestations of these patients, the systemic ones versus the respiratory ones. But also when we look at the histological features of the disease, and we go back to the seminal paper by Jürgen Strauss, 1951, so more than 70 years ago, we will see that the main features of the disease are pretty different. So we see vasculitic lesions. As you can see, there's a typical segmental fibrinoid necrosis of the vesicle wall and an inflammatory response, which is dominated by eosinophilic leukocytes. But some other features are not vasculitic, are more granulomatous, and this is the reason why the name of the disease is now eosinophilic granulomatosis with polyangiitis. And then we also have some eosinophilic infiltrates which do not have a granulomatous appearance. So even histologically, we have different things, and a sort of segregation of lesions into vasculitic and sort of eosinophilic. And the eosinophilic ones can be either granulomatous or non-granulomatous. But of course, there is an overlap between the two, and we have patients that have eosinophilic vasculitis. But anyway, let's keep in mind that the clinical presentation, two main orders of features, the histological ones we will go through. And as you can see, there are eosinophilic infiltrates. This is, I think, a beautiful picture from a nasal biopsy where you can see a lot of eosinophils infiltrating the tissue, but no structural aggregation. Whereas in this case, we have a sort of a granulomatous reaction, which is dominated by eosinophils. But EGPA is not only eosinophilic disease. And if we go and analyze the biopsies of, for instance, of cutaneous purpura, we can also see lesions that do not harbor a sort of eosinophilic infiltrate. And these are mainly leukocytoclastic vasculitis of the dermal vessels, as you can see in this picture. And even if, also if you look at kidney lesions, most of the times these kidney lesions, which can be classified as crescentic nicotizing glomerulonephritis, although they're usually less severe, less diffuse, and less pronounced than the types of glomerulonephritis that we find in patients with GPA or MPA. But these lesions often do not have a marked eosinophilic infiltration. So it appears also from a histological point of view that the disease follows two main paths. One is dominated by eosinophils, and the other one is a sort of, more vasculitic path. And this dichotomy, which appears also in when we analyze patients with, when we analyze the different clinical manifestations of the patients, and this is a summary of different series, one from France, one from Italy, and one from the US. They consistently showed that some features, particularly alveolar hemorrhage or cutaneous purpura, glomerulonephritis in particular, and also mononeuritis multiplex, are more frequent in patients with ANCA-positive disease than in patients with ANCA-negative disease. ANCA are usually positive in about 35 to 40% of patients with EGPA, and they probably represent a sort of subset. And so all of these features that segregate into different subsets, both histologically and clinically, recognized as sort of ANCA-based nature. And this is also a sort of pictorial representation of the ANCA-positive and ANCA-negative subsets, where we see that there are common features, and these are usually eosinophilia, chronic rhinosinusitis, and asthma, which you can find at similar frequencies in the two subsets, whereas the clinical manifestations such as glomerulonephritis, peripheral neuropathy, and purpura dominate in patients with ANCA-positive disease, and they are more reminiscent of a vasculitic phenotype, whereas the ANCA-negative subset usually shows more frequently than the ANCA-positive ones, shows cardiomyopathy, gastroenteritis, lung infiltrates, which are usually more eosinophilic. But this is okay, and but not all the glitters is gold, and we know that on the single patient level, there is an overlap between the two. So we cannot really classify a patient as ANCA-positive as being vasculitic or an ANCA-negative one as being eosinophilic. And a work, a cluster analysis run by Alfred, which is underway now, showed clearly that at the patient level, it is not possible to find these two subsets. But nevertheless, there are probably mechanisms that operate in the two different subsets and that dominate in the two different subsets. EGPA is a complex disease, and when we define a complex disease, we usually think of a disease where genetic predisposition operates together with environmental factors and shapes the phenotype of the disease. We run this study on a very small cohort of patients with EGPA and healthy controls, analyzing HLA variants. And we found that we were the first to define that there was an HLA class 2 association of EGPA. And when we looked at the different frequency of this HLA-DRB4 marker in patients with different levels of vasculitic manifestations, so with different numbers of vasculitic manifestations, we could see that there was a trend towards a more pronounced DRB4 positivity in patients with a more vasculitic phenotype. And also when we run another immune genetic study looking at the copy number variations of the Fc gamma receptor 3b, we also found that there was a deficiency in patients with EGPA in terms of CNV of this gene. And this deficiency was particularly enriched in patients with vasculitic features, such as renal disease, and particularly those with reduced EGFR, peripheral neuropathy, and purpura. And all these genetic studies culminated in the GWAS. And this was the sort of the prince of all these genetic studies, and I think one of the most informative studies ever performed in EGPA. More than 500 patients recruited. You can see the Manhattan plot of all cases, which clearly shows that there is a peak on chromosome 6, which means HLA association. But when the patients were divided into those with MPO-ANCA positivity and MPO and ANCA negativity, the surprise came. And where the MPO-ANCA positive subset is made of about 1/3 of the whole cohort, and you can see that the peak is still on chromosome 6, but the statistical significance of this association is even greater than in the general population. And this is even harder if you think that the subset is smaller than the whole cohort. So the association is very strong. And apparently this accounts for the association in the entire population, because when you look at ANCA-negative patients, there is no HLA peak. So this means that the HLA association is limited to patients with MPO-ANCA disease. But the ANCA-negative subset also showed significant associations, and these were mainly with genes encoding proteins involved in eosinophil biology, such as IL-5, and also in mucosal disease, in sort of mucosal integrity, such as GPA33. So on one side, we have gene variants in the ANCA-negative subset, which control eosinophil biology and mucosal integrity. On the other side, so on the ANCA-positive subset, we have a typical HLA class 2 association, similar to what we found in other ANCA-associated vasculitis, and in particular in MPA, which is an MPO ANCA-positive disease. But the GWAS also gave us other information. So these are the exclusive features of the two subsets, but there are also other gene variants which sort of span over, which go over the entire spectrum of the disease. And these include TSLP, BAC2, GATA3, which are all drivers of the Th2 responses. And these gene variants control eosinophil counts in the general population, are a risk factor for asthma in the general population. So it is very nice to see that this genetic study recapitulated the entire pathogenesis of the disease. So there are common genes, and that these explain probably, the core of what we saw in the Matryoshka structure. And this is the Th2 reaction, which is mainly in the respiratory and the eosinophilic field. And then we have other systemic manifestations that segregate into two subsets. But being a complex disease means that there are also environmental factors which can contribute to the pathogenesis. And we run a case control study with 111 patients with EGPA and 333 controls. And we were able to define that usual risk factors for ANCA-associated vasculitis, such as silica and farming exposure, but also organic solvents were risk factors for EGPA as well. And the interaction between the different factors was also sometimes multiplicative. So there was a synergic effect of all these factors. But it was nice to see also that organic solvents predominated in the ANCA-negative patients and the silica and farming in the ANCA-positive patients. This is nice because it parallels what we see in ANCA vasculitis, in ANCA-associated vasculitis, where silica and farming are known risk factors, whereas the organic solvents mainly segregate in the ANCA-negative subset, which is the one where probably the mucosal integrity, so the interaction with toxic agents, can be a major determinant of the pathogenesis of the disease. This is a Th2 disease. Most of the manifestations are those of a Th2 disease, so everyone could hypothesize that there are allergens driving the disease, but these are actually not, at least not the common allergens. And in this study, which follows a previous study run by Alberto Sinigo, this was a sort of follow-up study. We tested the common allergen reactivity in patients with active EGPA, inactive EGPA, atopic asthma, healthy controls, and ANCA-associated vasculitis. And here you can see the reactivity and the intensity of the color is the degree of reactivity. And you can see that probably the reactivity towards common allergens in patients with EGPA, regardless of the activity of the disease activity, is generally lower than in patients with asthma, and it's comparable to what happens in healthy controls. So apparently, common allergens are not the drivers of the disease. There might be other allergens, but we don't know. But anyway, we're convinced that the interaction between genetic predisposition and the environment plays a role. And we also hypothesize that there might be epigenetic changes which are driven by environmental factors and control the expression of some genes. And we have an ongoing study which has recently been funded on the epigenome of EGPA patients. But let's go and see which cell types and which mechanisms are involved in the pathogenesis of the disease. Certainly T cells are key cells in the immune pathogenesis of EGPA. One study performed more than 20 years ago by Marcus Mushin defined that T cells are oligoclonally expanded, and this is a proof of an antigen-driven disease. When you have a restricted variety of antigens which can induce a disease, this is something that we observe in many HLA class 2 linked diseases, and EGPA, at least for the ANCA-positive subset is one of those. And then there is a crosstalk between T cells and eosinophils. T cells can control eosinophils in many ways through the secretion of IL-5, IL-4, IL-13, we will see later on. But there's also direct crosstalk, and this study investigated the role of this pathway, which is the CD95 ligand control pathway, which is an apoptosis pathway. So usually what the authors were able to define is that EGPA lymphocytes usually exhibit a switch from the membrane-bound CD95 receptor to its soluble splice variant. So when this receptor is no longer on the lymphocytes, these lymphocytes do not undergo apoptosis, so they survive more. But at the same time, it's intriguing to see that the soluble form of the CD95 is a mitogen for eosinophils. So on one side, you see lymphocytes that never die, and on the other side, you have the same system that controls eosinophil proliferation. This is very nice. It appears that there's a dysregulation in the crosstalk between T cells and eosinophils. What kind of T cells? What kind of lymphocytes? There is a sort of new subset of cells which are called innate lymphoid cells, and the type 2 of these cells is a major controller of the Th2 responses. And in the work led by Benjamin Terrier performed in the United States, they were able to show that patients with EGPA have an increased level of cytokines and chemokines that control ILC2 activation. And these cytokines include IL-25 and especially TSLP, which are increased in patients with EGPA and especially in patients with active EGPA. And ILC2 cells, where are they? They are not in the circulation because their levels in the circulation are lower, but they are in the tissue, so they probably mediate the inflammatory response. And in the mouse model, the only mouse model of EGPA or eosinophilic vasculitis that was generated in this work, they were able to show that ILC2, so innate lymphoid cells type 2, are key to the pathogenesis of eosinophilic vasculitis, and their activation depends on the presence of IL-33, which is a cytokine that in mouse models that were transgenic for the expression of IL-5, were able to promote the development of eosinophilic vasculitis. So an increased constitutive expression of IL-5 together with IL-33 is able to drive the reaction towards a very strong Th2 reaction, which ends up in the formation of eosinophilic vasculitic lesions. B cells also play a role, and B cells crosstalk with T cells. So B cells, we know from the clinical experience that when we treat patients with rituximab, we have a depletion of B cells. And what Alan Salama and Ruth Pepper observed in 2 cases some years ago was that eosinophils also go down soon after the administration of rituximab, and it was also in parallel with the decrease of IL-5. So this is very interesting. It probably means that when we deplete B cells, we deplete the source of antigen-presenting cells, which are no longer able to induce T cell activation and T cell production of IL-5. And so this, in turn, leads to the decrease of eosinophils. And also Giacomo showed in patients treated with rituximab in observational studies that we have a decrease of eosinophil counts in the periphery. So B cells are certainly key to the pathogenesis and also to eosinophilic activation. And B cells are...
Augusto, we have five minutes left for the webinar, just to let you know.
Yeah, I'm almost done. We also have a dysregulated immune response, which is characterized also by an increase in IgG4 in patients with active disease. And we also have resident cells which participate in the inflammatory reaction through the secretion of chemokines such as eotaxin 3, which is expressed by endothelial cells, epithelial cells, and so on. Eosinophils are the main drivers of the tissue damage, and this is by different mechanisms, necrosis, but also apoptosis. In this case of eosinophilic myocarditis, we could demonstrate that cardiomyocytes also undergo apoptosis under the influence of eosinophils. And to conclude, this is the final model that we hypothesize in EGPA. We have certainly two subsets. The ANCA positive subset is the one driven by adaptive immunity and by the HLA predisposition and the involvement of probably of antigens and allergens, and this drives vasculitis, whereas the ANCA negative subset is mainly a mucosal disease where the mucosal integrity is broken and activates the eosinophils. The two subsets may then converge into a single lesion and into a complex phenotype of these patients. Thanks very much.
Thank you very much, Augusto. What a fantastic explanation for our audience. It's so important is the underlying genetic underpin for EGPA, and it does suggest and explain why there's such heterogeneity in the clinical presentation, wouldn't you say?
Well, I think the genetic studies of the GWAS is fantastic explanation of the disease. It's probably too clear. It's even clearer than what we see in the clinical practice. I think that this segregation of signals means that there is really a segregation of what is the pathogenic mechanisms, and then we have other stuff going on that shapes the disease. The disease is more complex than just an ANCA positive and ANCA based, an ANCA negative based dichotomy. So I think genetic predisposition is something. It fits very well with the pathogenesis of the disease, but there might be other stuff, drugs or infections or whatever, that really help to shape the phenotype. I don't know if I answered your question.
You did very well, and you also really importantly highlighted it's not only our serum but also the understanding what's happening at the tissue level for EGPA with both the innate lymphoid cells and also with the eosinophils being present, that our understanding of tissue biopsy within EGPA is important.
Yeah, I think this is certainly not been studied in depth. And I think we should make an effort to collect more biopsies and to understand what happens. What I see from the biopsies that I've seen in my clinical experience and also in published studies is that, as I showed you, there are some lesions that are more eosinophilic and other lesions are more vasculitic, and some vasculitic lesions also have a very low amount of eosinophils. So the eosinophilic vasculitis is like the combination of everything, but it's not the rule, and I would say that it's quite exceptional. So I think that really the biopsies help us understand, and the mouse model by Benjamin is a very elegant one, but we don't know how far or how close it is to the clinical ones. So innate lymphoid cells were also studied in humans, in EGPA patients in the same study, and it appears that they are trapped in the tissue, but the mechanisms are not clear yet.
Thank you very much.
Ellie, we're a little bit running out of time. I would still like to ask 2 or 3 questions in the chat. Some are coming from persons who obviously have EGPA. Augusto, are you ready? So one question is, when remission has been achieved and maintenance is going well with no flares, is it possible to come off all medications?
Yeah, we have a few patients that come off medications for many years or maybe forever. But these are patients that, I mean, you should always try and taper down glucocorticoids and also, if possible, to space out a little bit the administration of anti-IL-5 or other maintenance drugs. We have experience with a few patients, and I think it's they usually had I mean, in my experience, they had a less severe disease already at the beginning. But I don't think it's a rule. I think the fraction of patients that really come off treatment is very low. But I don't think this is the goal. I mean, the goal is to reduce as much as possible, but we can accept to have a very low doses of glucocorticoids or non-toxic drugs such as IL-5 inhibitors. I think it's a good compromise. I think it's a good compromise between disease control and toxicity.
There's a related question, which is, hi, I'm in clinical remission taking 20 milligrams of methotrexate per week. What is the toxicity long-term, sorry. Toxicity of methotrexate, 20 milligrams per week in the long term.
Yeah, we know that this drug has different levels, different types of toxicity, which can be hepatic, which can be bone marrow or pulmonary, whatever, and this is dose related. Generally, it's a well-tolerated drug. It's been used in rheumatoid arthritis or different types of arthritis for many years and even for decades with no big concerns. But I would try and reduce the dose of methotrexate because in my experience, 20 milligrams is really too much. We usually have patients on 7.5 milligrams per week, if any, and the efficacy of methotrexate in EGPA is still to be proven. So my advice would be to reduce.
And last question from the chat, a person that had been treated with mepolizumab in addition to prednisone, not feeling well with it, barely able to function, then switched to benralizumab and feeling great, with being able to taper prednisone down to 3.5 milligram per day. Is benralizumab ahead of mepolizumab?
I think it's a good option. It's a good drug. We have an observational study now showing very good results. And I think it's not possible to compare it to mepolizumab right now, but we will have data in the future. So I think if the patient is okay on Benra, should continue Benra.
Very good. So it's good to have different options. So last question that just came in, and then we will wrap up the session. Can you break down mortality figures? 80% survival after 5 years.
Sorry, can you repeat, Alfred?
Can you break down mortality figures? 80% survival after 5 years. I guess the question is if this is really reflecting your experience. 20% mortality within 5 years.
I think it's a little bit too much, this figure. I think it's greater than what we see in clinical practice. I don't see an excess mortality in patients with EGPA in the long term. And you have to consider also that the age at onset is quite young. I mean, it's 45 to 50 years. So I think 20% mortality is a figure that we should revise. We should rethink of in future studies on survival. I think this probably reflects past practice.
That leaves us with an optimistic last message. Ali, would you like to wrap up the session?
Thank you, Augusto. Fantastic presentation, and Giacomo, what an hour it's been. It's a tour de force. It shows our understanding of EGPA is advancing on several levels, other therapeutic options. I think the future is bright for EGPA. I think it needs to be. It's a double hit steroid dependency condition, and I think it's very warranted. We're very optimistic here. Thank you for joining us. It's a combined EUVAS, ERN-RITA seminar. We hope you've loved it. Do come back for more of ERN-RITA, and we hope to see you very soon. Thank you to all involved in the webinar today.
Have a nice day. Thank you. Bye-bye.
Replays of the webinars can be watched on the ERN-RITA website. Please check it out. Thank you so much. Have a good afternoon.
Bye-bye.
Bye-bye, Augusto.
Thank you. Bye, Augusto.
Bye-bye.
Goodbye, Alfred.
Thank you, Ali.